It's a pleasure for me to be able to talk to you today about the continuing value of the 12-lead electrocardiogram. And I'm going to base this on the work which we have been doing in the University of Glasgow to develop software for automated interpretation of the electrocardiogram. First of all, let me welcome you from Scotland and hope that someday you may be visiting us. Here we have a view of the famous Loch Ness, the home of the monster, and maybe if you look hard enough you might just be able to see something in the water there. I'm linked with the University of Glasgow. In fact, I'm on the staff of the university, and I work in the Royal Infirmary, which is about a couple of miles distant from the university. Let's begin at the beginning. The first human ECG was said to have been recorded by Waller in 1887. Here we can see how he has recorded the ECG with electrodes on the front and the back of the chest, and the potential difference between the electrodes drove a mercury column up and down on the left-hand side. Waller recorded the movements of the mercury column, and the black and white interface on this figure here actually represents the first human ECG. In 1902, a Dutch physician, Willem Einthoven, laid the foundations of 12-lead electrocardiography as we know it today. Here we see a patient with effectively electrodes connected to the left arm and the left leg, and in the upper right you will see wires which lead the potential difference between these two electrodes back to the recording equipment, which was in the physiology lab about half a mile from the hospital. In the bottom we can see the 12-lead, or the lead 2, and the lead 3 as recorded by Einthoven at that time. The first commercially available ECG machine was built in England around about 1920, and here we can see an illustration. Now let's look at the conduction system of the heart. As you'll know, activation begins in the sinus node under normal circumstances in the right atrium, spreads through the atria, is picked up in the bundle of His, and then conducted to the ventricles via the right and left bundle branches and out into the myocardium via the Purkinje fibers. Einthoven's leads are shown here. Lead 1 recorded the potential difference between the left arm and the right arm. Lead 2 recorded the potential difference between the left leg and the right arm. And lead 3, the potential difference between the left leg and the left arm. Any one of these leads would have recorded a waveform as we see here, where the P wave represents atrial activity, the QRS complex is ventricular depolarization, and the T wave is due to ventricular repolarization. Einthoven introduced this triangle as an aid to remembering the links between the three bipolar limb leads. Here we can see the horizontal line 1, lead 1, which shows the direction in which a positive deflection would be recorded. In other words, the arrow is pointing from right to left, so that if current flow is predominantly in that direction, then by convention there would be an upward deflection in lead 1. Lead 2 would similarly measure or display an upward deflection if current flow was predominantly in a southeasterly direction. And lead 3 would show an upward deflection if current flow was predominantly in a southwesterly direction, as indicated by the triangle. So there's a direction associated with each lead, and to put it another way, these leads record a component of the electrical activity of the heart in the directions with which they are associated. In the early 1930s, an American physician, Wilson, introduced his central terminal. This was achieved by connecting the electrodes at the right arm, the left arm, and the left leg to a common point, and that the potential there was the average of the potentials at the right arm, and left leg. this gave a relatively constant potential, not a zero potential, but a constant, relatively constant potential. If that was linked to one side of a galvanometer or measuring device, and the other side of the galvanometer was linked to an electrode at any point in the body, here represented by the letter P, then that recorded a unipolar lead, which basically reflected the potential variation at the point P. We can see this in the diagram here. On the top left, we have a representation of the potential variation at the point P, and below we have the relatively constant potential of the Wilson central terminal. Now the recording device would subtract the one from the other, and that would give us the waveform on the right-hand side, which basically is similar to the waveform in the top left-hand side. So that is a unipolar lead made by recording potential difference at any point in the body with respect to the Wilson central terminal. In the early 1940s, cardiologists agreed to standardize on 6 electrode positions on the chest, here denoted V1 to V6. V1 and V2 are placed either side of the sternum at the 4th intercostal space. V4 is in the midclavicular line in the 5th intercostal space. And let me repeat, only one interspace difference between V2 and V4. V3 is positioned intermediate to V3 and V4. V6 is in the left mid-axilla at the same horizontal level as V4, and V5 can be positioned midway between V4 and V6. Note in the bottom left that the limb electrodes are attached to the wrists and the ankles. I stress this, that the limb electrodes should be placed on the arms and legs and not the thorax. If these electrodes are not placed on the limbs, they do not record limb leads. Now, I've talked about unipolar chest leads, but what about unipolar limb leads? Well, a unipolar limb lead records the potential difference between a limb electrode and the Wilson central terminal. Here, for example, we see the unipolar limb lead VL, which measures the potential difference between the left arm and the Wilson central terminal. We can have similar equations for VR and VF. In the early 1940s, Goldberger modified the circuitry very slightly for recording these limb leads, unipolar limb leads, so that the gain was increased by 50%. And that led to the introduction of the augmented unipolar limb leads. And here we show AVL equal to 1.5 times VL. So there are 3 such leads, AVR, AVL, and AVF. And this gives us our 12-lead ECG. 3 bipolar limb leads, 1, 2, and 3. 3 augmented unipolar limb leads, AVR, AVL, and AVF. And 6 unipolar chest leads, V1 to V6. I showed you earlier the directions associated with 1, 2, 3, and we see these same directions on this diagram, except that V3 is linked to a central point along with 1 and 2. We can now add in the directions associated with AVL, AVF, and AVR as shown on the diagram. What this tells us, for example, is if the current is flowing through the heart mainly in a southeasterly direction, i.e. in the direction of lead 2, where a positive deflection would be recorded, then it is flowing away from the direction in which AVR would record a positive deflection, and hence AVR records a negative or a downward waveform. For the precordial leads, we see the directions associated here in the transverse plane, V1 through to V6. These are approximate directions in which components of the cardiac electrical activity are being recorded. And this brings us to an example of a normal ECG in a male aged 45 years. And note how, for example, lead 2 in this case has an upward QRS deflection, a tall R wave, whereas AVR is almost equal and opposite, with a predominantly downward QRS deflection or an S wave and T wave inversion, as explained in earlier diagrams. Now let's look at how we might approach ECG interpretation. First of all, of course, we have to print the ECG on paper, and conventionally the gain is set as 10 millimeters being equal to 1 millivolt, and from a timing point of view, paper speed is equivalent to 25 millimeters per second. This is the most commonly used paper speed, and that means that one small box is equivalent to 0.04 seconds or 40 milliseconds, and one large box is 0.2 of a second or 200 milliseconds. Now look carefully at this diagram where we see two different patterns. On the left, we have the upright QRS waveform in the normal ECG, commonly seen in leads 1, 2, AVF, V5 and V6. On the right, we have more of a deep S wave in V1 and V2, commonly seen in the normal ECG in leads V1, V2 and sometimes V3. Now I would suggest that you maybe copy down only these two patterns, and I think you will find that you should be able to determine whether an ECG is normal or abnormal by comparing these two patterns with any ECG with which you are confronted. So these are a guide to interpreting an ECG, or a normal ECG in particular, and hence anything which is not normal. This slide shows a scheme for reporting ECGs, and we're going to run through quickly each of the different categories listed. In so doing, I will make use of reports produced by the Glasgow Programme for Automated ECG Interpretation. And let me say a word about the technique. The automated report provides a second opinion to those with limited experience of ECG interpretation. It also provides a second opinion even to those with significant experience of ECG interpretation. Inter and intra-observer variation in ECG interpretation is well known, and hence a second opinion can be worthwhile to anyone looking at an ECG. But a word of warning, automated interpretation cannot be regarded as 100% correct either, and indeed, given inter and intra-observer variation, I would argue that a cardiologist cannot be regarded as 100% correct either, at least according to his peers. The automated interpretation program developed in Glasgow makes very significant use of the patient's age, sex, and we also smooth the limits of normality. It really doesn't make sense to say that if a voltage is just marginally below a threshold, then the ECG is normal, and if the voltage is marginally above the threshold, then it's abnormal. So we try to smooth the borderline between normality and abnormality, and that applies in a sense to the criteria. The software is also able to make use of the patient's drug therapy if it's input to the program, and also the patient's clinical history, and we'll see one example of that. This shows a typical automated ECG interpretation machine where there's a keyboard that allows you to input name, patient details, clinical history, etc. A typical printout on the left-hand side and a monitoring screen to look at the quality of the recording. One thing the computer can do within limits is to smooth out some of the more poorly recorded segments of an ECG. Here we see an example where there's a lot of baseline wander, particularly in V2, and yet if we look at the average beats shown on the right-hand side, we'll see that the average for V2 is rather clean and there is no baseline wander evident. I've already spoken about electrode positioning, and this is just to show how electrodes can be wrongly positioned. V1 and V2, for example, are separated from V4 to V6 by more than one interspace. So I would suggest here that we have an example of faulty chest electrode positioning, to put it mildly. So you have to be very careful when positioning electrodes. Now, one thing the automated system can do is try to guide you if the software thinks electrodes have been wrongly positioned. And this first example shows in V1 and V2 RSR- patterns with T-wave inversion and inverted P waves, which are almost identical. And this is a classical sign of the V1 and V2 electrodes being positioned too highly on the chest. So the software can help you detect problems with electrode positioning. Similarly, here we see a flat lead 3, and again the software detects a problem with the limb lead positioning, and hence the leads V1 to V6 are the only leads which are analysed and the limb leads are omitted. And finally, here's another example of electrode positioning problems where the left and right arm electrodes have been interchanged, and therefore lead 1 is inverted and most of the other limb leads are therefore wrongly recorded. The program in this case reports arm lead reversal and only leads AVF and V1 to V6 are used in the interpretation. Now for the basic interpretation, and the first aspect of this is to look at the rate. A quick way to measure rate is to measure the number of large boxes between the average RR interval and divide that into 300. In this case, we have approximately 4.5 large boxes between consecutive QRS complexes. If we divide 4.5 into 300, then we find a rate of 66 per minute approximately. And this ties in with the computer report. Rhythm is the next aspect of interpretation. This can only, accurate rhythm interpretation can only be achieved through experience, but in this case, here we have an ECG with irregular RR intervals. There's a lack of a P wave, and this is consistent with atrial fibrillation as reported by the computer. It also points to the fact that there's rapid ventricular response. On the other hand, here we have another ECG where we can see in the bottom tracing in V1 some fibrillatory waves, a slower heart rate in this case, but there are no regular P waves, and so again this is another example of atrial fibrillation. Then in the sequence we move on to looking at P waves and atrial activity. This example shows peaked P waves in the inferior lead 2 and AVF. And this is suggestive of a right atrial abnormality, increased P wave amplitude, inferior leads suggesting right atrial abnormality. We look then at the various intervals, PR, QRS, QT interval. Here is another complex example where the PR interval exceeds 220 milliseconds and therefore we would report first degree AV block. The QT interval, the corrected QT interval, exceeds 470 milliseconds and therefore we have a long QT. It is customary to adjust the QT interval using one of several formula so that we find the expected QT interval at a heart rate of 60, and that is known as the corrected QT. And in this case, QT, C for corrected, is greater than 470 milliseconds. So here we have an ECG where the intervals are abnormal. PR and QT intervals are abnormal. And note, only an ECG can provide this information. We then move on to look at QRS axis. Now here we can see a schema of the heart on which we superimpose the different lead axes as discussed earlier. Now the red area shows the normal limits of QRS axis. In other words, the normal limits of the dominant spread of activation. So anything superior to AVL, above AVL, which is minus 30, would be abnormal, that would be left axis deviation. And anything to the left, as you look at it, of lead AVF, or a more inferior shift, it would be right axis deviation. So that's greater than 90 degrees. Now in practice, the normal ECG would have an upright QRS complex in leads 1 and 2, whereas if there was left axis deviation, lead 2 would be predominantly negative. If there was right axis deviation, lead 1 would be predominantly negative, with lead 2 positive. So here we have examples, and on the left axis deviation, where lead 2 is predominantly negative and lead 3 is clearly negative. And on the right of the slide, we have right axis deviation, where there is a prominent S wave in lead 1, but lead 2 and lead 3 are upright. So here's an example, the one that we saw earlier actually, of left axis deviation. QRS axis is less than minus 30 degrees. It's superior to minus 30 degrees. On the other hand, here we have the other example with right axis deviation, where the axis is greater than 110 degrees. So this is an example of right axis deviation with a prominent S wave in lead 1 and an upright R wave in 2 and 3. We then move on to look at the QRS morphology, and I can only show a few examples of abnormality here. The first one, if you look at V1, you will see an RSR dash, a kind of M-shaped complex, and the QRS duration is greater than 120 milliseconds, so it's abnormal. In lead 1 and V6, you will find a broad S wave, and this is consistent with right bundle branch block, a conduction defect which mainly affects the second part or the latter part of ventricular excitation. Contrast that with left bundle branch block shown here, where there is a wide QRS complex, and we see a broad R wave in 1 and V6 and a QS complex in V1. And this is consistent with a left bundle branch block. Another conduction abnormality is the Wolff-Parkinson-White pattern shown here, where there is a short circuit, an accessory pathway between the atria and the ventricles. This can be seen from the slow upstroke of the QRS complex, and this is known as a delta wave. It is generally accompanied by a short PR interval. There are many different forms of the WPW pattern depending on the location of the accessory pathway, and this is just one. But the main features, short PR interval and delta waves together with a wide QRS complex. And again, only an ECG can provide this information, which is why I referred at the outset to the continued value of the electrocardiogram. So we move on with one or two other examples of the QRS morphology being abnormal. And in this case, we have a situation where there's a tall R wave in V5 and V6, together with asymmetric T wave inversion, and that is suggestive of left ventricular hypertrophy. And that's what's reported by the computer. It also suggests that the T wave abnormalities may in part be due to myocardial ischemia, because it can be difficult, if not impossible, to sort out changes due to LVH versus those due to myocardial ischemia. On the other hand, this example shows right ventricular hypertrophy. The main feature here is the deep S wave in V5 and V6, together with the right axis deviation that we have discussed previously. So, right ventricular hypertrophy. Then we move finally to STT changes. In this case, we have some rather dramatic ST elevation in V2 through to V6, also in the lateral leads 1 and AVL. This is accompanied by a reciprocal ST depression in the inferior leads 3 and AVF. And this is a classic ECG showing the signs of an acute myocardial infarction. And in the very top of the computer interpretation, you will see consider acute STEMI. We call these headlines critical values. STEMI, of course, being ST elevation myocardial infarction. And this is important in the diagnosis and treatment of a patient with acute chest pain. This final example shows ST depression in the lateral leads, anterolateral leads, V5 and V6. And so we have T-wave abnormalities which can be difficult to interpret. Now in this case, we note that the patient has a clinical diagnosis of hypertension, and we make use of that in the interpretation by saying that these changes could be due to hypertension or myocardial ischemia. Now remember that a computer program can store diagnostic ECG criteria for patients of all ages and both sexes. Which brings me to this example from a normal ECG from a neonate aged 1 day. Note here, you might think there was a right axis deviation because of the deep S wave in lead 1, and there are tall R waves in V2, and also in V4R, which we use in the neonate. And these are normal for the neonate. So we can build these normal limits into our software. So therefore, the computer program really does have the ability to interpret ECGs from patients of all ages. Now, the benefit of the automated reporting technique is that it can be of value to family practitioners, our junior medical staff who have to deal with patients of all ages. The computer can check normal limits for males and females, as these differ particularly in young adults. And the ECG remains the only tool for detecting certain abnormalities, conduction defects, prolonged PR interval, long QT, etc., etc. And finally, automated ECG interpretation can provide significant assistance to medical and paramedical staff in ECG reporting. Now, I leave you with a few slides from one of the most beautiful islands in Scotland, and hope that one day you might find your way over to Scotland, and we look forward to welcoming you at that time. Thank you.